Okay, so we're going to move on to our next two topics that I want to discuss. And these two subjects are located in chapter 33. And we're going to look at sickle cell disorder and we're going to look at hemophilia. But in general, if you're caring for a patient with a hematologic, hematologic dysfunction, your assessment isn't going to be any different. No matter if it's hemophilia, idiopathic thrombocytopenia, or sickle cell, you still need to look at some basic things. First thing you want to look at is a complete blood cell count. You need to see where are the red blood cells, where is their hemoglobin, hematocrit, white blood cell count. Platelets are very important when looking at a hematologic dysfunction. And then there are some others that you want to look at, such as SED rate, a reticulocyte rate, clotting times. All of those become important when you're assessing a patient with a dysfunction of blood. So your history and physical examination. History, is this new? Is this a recurrence? Is there a family history? Many blood disorders tend to be passed down family member to family member. It may be from male to male or female to male, but the traits are passed down. So find out the family history. Physical examination, you want to look at color. What is their color? This is where you turn that bright light on in a room, even if it's just for a couple minutes to get a good look at their color. What color are their lips, their nail beds? Look at their mucous membranes around their gums. Are they dusky? Are they cyanotic? Are they waxy? Waxy doesn't necessarily imply that there's an oxygenation issue, but they may be anemic. You want to inquire about the child's energy level. Are they easily fatigued? Are they sleeping more than usual? Look at nutrition. When I mentioned anemic, are they getting in enough iron? Taking in protein? How frequently are they coming down with infections? Does it seem like any kind of little bug winds up with as a major infection for that child? And have they noticed an increase in bruising or bleeding, excess bleeding, or difficulty stopping bleeding? This is all pretty standard no matter the type of hematologic dysfunction, but this is all stuff you need to look at. Moving on to sickle cell anemia, and like I said, it starts in your textbook on page 1077. I'll just read that section. But sickle cell anemia is considered an autosomal recessive disorder. Anywhere from 8 to 9% of African Americans are carriers, meaning they have sickle cell traits. And it's not just African Americans. You may also see Mediterranean people with Mediterranean descent. May also carry a sickle cell trait. If both parents have the trait, each of their children will have a 25% chance of having the disease. So just a little interesting tidbit is that it seems like in areas where malaria is common in the world, people who have sickle cell trait tend to fare better against that disease than those without that trait. So there is just a school of thought that perhaps through evolvement, that may be why that sickling trait occurred, is because in that region it helped to combat malaria virus. So continuing on, with sickle cell, what happens is the red blood cells are misshapen and they become sickled, like so in a crescent shape. If somebody is into a sickle cell crisis, They're going to produce more sickled red blood cells. You'll also see vascular inflammation, and there will be an increased red blood cell destruction. And because of these odd-shaped red blood cells, you're going to see them entangling with each other, causing thrombi. And by causing a thrombi, it then can cause an occlusion. Typically, it'll be in the microvascular areas, which will cause hypoxia and eventual cell death to the tissue. So there's a neat picture in your book on page 1078 that shows healthy red blood cells and sickled cells. And here's a diagram. And this diagram also outlines for you all of the potential injuries that can occur if someone is experiencing a sickle cell crisis where they've had thrombi and injury is occurring to the tissue. The average life expectancy is up into the 5th decade, so in their 50s. Doesn't say that they have a great quality of life into their 50s, but the average life expectancy is into their 50s. Commonly, you'll see these patients will have experienced a stroke of some time. They may have partial to full blindness due to damage to the retina. They may have amputations of their hands or feet, depending on injuries that have occurred from the thrombi. And it's not unusual that they will not have a spleen either. Those usually come out in their late school age to mid-adolescent years. Because of splenic sequestration, which is where basically the spleen becomes overfilled to the point of bursting, and all of that containment puts pressure on the tissue, causing necrosis, so it becomes necessary to go in and remove the spleen. So what happens is the sickle cell trait, they will have some sickled cells, and as long as the person is hydrated and the vasculature is not inflamed, they can progress with no complications and be asymptomatic. But if they become slightly dehydrated or there's an infection and it pushes them into what's called a crisis, then all of a sudden, instead of the cells slipping and sliding over each other, you're going to see what is diagrammed here on the bottom, B. So you'll see a clot form, just like you see in image B. And when this clot forms, depending on where it is located at, then you will see hypoxia and tissue death occurring. So currently there is no cure for sickle cell anemia. They have tried bone marrow transplantation, and it can put them in remission for a while, but it's not known as a cure. One of the things they have started doing is apheresis, which is kind of like a dialysis, but basically they draw the blood out and they filter all of the sickled cells out, and they put the blood back in. And they have seen some success with this. While it's a continuous treatment that they have to do, and it varies each child. It may be every 3 weeks or every month or 2 months they have to come in and have apheresis done, but it reduces the number of crises that they have occurring. So treatment then is a supportive care. You want to prevent sickling episodes, so you want to be very careful about preventing infections, because one, they're already somewhat immunocompromised, but then two, the mildest of infections can then trigger a sickling episode. I think that covers that slide. So sickle cell crisis is when something stresses the body, the vascular system. You'll see increased blood viscosity because of dehydration. possibly an infection. All of these things can trigger the crisis. So first thing you do when you have somebody come in who's in a sickle cell crisis, there is definitely a priority of treatment there. So the first thing you want to do is hydrate them, okay? You want to try to separate those clumped cells as much as you can to make it easier for them to pass over each other. The next thing you'd want to do is administer an analgesic for pain. And there's a certain kind of analgesic you want to use. You want to use something morphine or Dilaudid because it causes vasodilation. And the vasodilation also allows for passing of the blood cells and reduces that clumping. It may be necessary to administer blood transfusions of healthy red blood cells. And then the final thing you must do is to treat whatever it is that is triggering the crisis. If it's an infection, if it's dehydration, do you need to administer steroids, antibiotics? You need to treat the cause of that. You may sometimes see someone taking prophylactic antibiotics for 2 months to 5 years, and this is just to keep a continuous level of antibiotics within the blood. And monitoring of the reticulocyte count is a regular assessment, and what that does is it evaluates bone marrow function and can kind of predict when a sickle cell crisis is impending by a rise in reticulocytes. Lots of education, seeking early interventions for fevers, prophylactic medication if necessary, recognizing signs and symptoms of splenic sequestration. And this is going to be abdominal pain, maybe diffuse abdominal pain, finally localizing in the upper left quadrant of the abdomen.